space where beauty meets authenticity and transformation is not just a possibility, but a promise. I'm absolutely thrilled to introduce you to someone truly special, Dr. Rukmini Vinaya-Rednam, the compassionate force behind the countless remarkable transformations in the vibrant city of Houston, Texas. Picture this: every curve, every contour crafted with care and expertise, not just by a board-certified plastic surgeon, but your very own cheerleader for self-discovery and confidence. Get ready to embark on a journey where we explore the art of science of feeling your very best self. This isn't just a podcast. It's your cozy corner of empowerment and inspiration. So pull up a chair, pour yourself a cup of kindness, and let's dive into the Confidence Doc podcast with Dr. Rukmini Vinaya-Rednam.
Welcome back to the Confidence Doc podcast. I am Dr. Rednam. I'm a board-certified plastic surgeon here in Houston, Texas. And I'm very, very excited about my guest today, Dr. Johanna Clowney. She is a board-certified anesthesiologist. And I know a lot of our listeners just don't know what anesthesiologists do. They don't know the very, very important role that they play in their surgery. So thank you so much for joining us today. So I thought we would start off by just explaining how it is one becomes an anesthesiologist. So could you share that with us?
Yeah. So anesthesiologists are medical doctors. So we go to medical school just like every other doctor. So there's 4 years of medical school. And then anesthesia residency is 4 years total, but the first year is sort of a choose your own adventure year. So you can do a year in internal medicine or a year in surgery in order to basically get your feet wet in the hospital setting, the clinical setting, and taking care of patients. After that first year, you move on to full anesthesia residency where you're just doing anesthesia, and that's another 3-year track. So at the end of that sort of 4-year block of time, you'll sit your boards, and then you are free to take care of patients as a board-certified anesthesiologist. There are some people who decide to further specialize within anesthesia and do another year of anesthesia in that specific area of anesthesia, which is basically called a fellowship. Fellowships in anesthesia include pain management, cardiac, obstetrics, and pediatrics. And so for me, I did an extra year in cardiac anesthesia, and that, allowed me to have a little bit more specialty experience in taking care of heart patients.
It's a little work to become an anesthesiologist.
It is a lot.
So tell us, why did you personally choose to become an anesthesiologist?
My decision was really based off of some really great mentors that I met in medical school, and they were anesthesiologists, and they happened to be very strong female anesthesiologists. And so that sort of lit my fire and really got my interest going. I always knew I wanted to do some type of medicine that was very hands-on, where you could do procedures. And really in medicine, that's only 2 specialties, and that would be anesthesia and surgery. And really based off the mentorship that I got as a medical student, that had me go that direction with anesthesia.
Okay. So I definitely want to focus today about your role in the operating room, because again, if I could tell you from my side of things, people are usually the most scared about the anesthesia. I think it's just because, again, it's the unknown. They don't know what to expect.
Yeah.
So can you kind of explain to our listeners what it is from the time you meet the patient, what your role is with this surgery?
Yeah, we like to consider ourselves in anesthesia sort of the last gatekeeper, right? So you've gone and done all your pre-op visits, and you've seen your physicians, and you're going to be presenting for surgery. Anesthesiologists are involved not just in the operating room, but before surgery, in the operating room, and after surgery, so taking care of that patient while they're in that surgical setting. So basically, we interview you, and in the preoperative area, we ask all the questions down to, every single aspect of your medical history to really start making an analysis about the safety of the anesthesia we're about to provide for you that day. So that's sort of the last gate. So sometimes we'll find out some things that we didn't know about before that may increase the risk for that patient under anesthesia. And then, we have to have further conversation. Assuming everything is fine and everything is good, we proceed on to the operating room. There, we put you off to sleep with medicine in an IV. or if it's just sedation, it's just the medicine in the IV. After that medicine in the IV, sometimes we'll place a breathing tube, just depending on the circumstances of the surgery. And we monitor your vital signs. And then at the end of surgery, that breathing tube comes out, we wake you up, and we take you to the recovery room. In the recovery room phase, we take care of any pain issues or if there's nausea, and basically make sure that your vital signs stay stable as you wake up from that anesthesia. And if your plan is to go home that day, we'll discharge you from there. If the plan is for you to stay overnight in the hospital, then you'll move on to your floor after that.
So there's a lot of involvement there. And even though as a patient, you may not be consciously aware that they're there, your anesthesiologist is so, so important in your care.
Yes.
So I will tell you, people will say, gosh, why didn't you ask me that question again? And what Dr. Clowney said is exactly that. It's like they're a new provider, they're a new doctor who's talking to you. So that's why they want to ask you the same questions that you might have felt like 10 other people asked you.
Yes. Yes.
So the other thing that we get a lot of too is people are like, well, why do I have to do all these tests? Why do I have to get clearances? And I always say, gosh, your anesthesiologist is going to be super disappointed if you don't. Can you explain a little bit about why clearances are important for some individuals?
Yeah, so everything that we do in medicine is a risk versus benefit analysis. And especially in anesthesia, that is very, very important to really weigh risk versus benefit. So is the risk of putting this patient under anesthesia and all the changes to the vital signs and everything like that, is that worth it to take that risk for the benefit of the endpoint of the surgery that they're having? We may ask for clearances, especially in patients who have other medical histories, people who have had heart stents before or heart surgery before, people who have had trouble with asthma where they've needed to be in the ICU and a breathing tube. We really need to understand exactly how severe the other medical problems are to really assess the risk. And since we're only meeting you that one day, it's a very short period of time that we get to interact with you. The clearances allow us to get a little bit better picture of what the long-term care you required prior to that day where you're having surgery. So again, as we may request cardiac clearance or clearance from a lung doctor or even clearance from an endocrinologist if you've had diabetes all your life, just to understand what the risk is so that we can make the best decision and the best choice for your anesthesia management for that day.
See, so that's why it is so important when you're like, gosh, my doctor's office keeps bugging me to get these clearances. It's because we want you to be safe at the end of the day. And it really helps that I worked with Dr. Clowney and her group for a long time. So we are good communicators. We know what they want. And I think that is a benefit to any places that you have good relationship with your anesthesia doctors, because then we can provide the best and safest care for our patients.
Yes, and that's actually been proven in the medical literature. The closer and the tighter the team is, so the surgeons, the anesthesiologists, the nurses in the room, if you have a really tight team, your risk of having a bad complication goes down tremendously. And that's been proven over and over in studies. And so that's why it's really important that we continue to have conversations about patients and their management.
And truthfully, it's a lot more fun for us too.
Yeah. You get to be friends after a while.
So this is a question. I'm going to shoot you with some questions that I get asked a lot. One is, why do you have to put a breathing tube in?
So in instances where the surgery is anticipated to take a long period of time, so usually about 2 hours is our cutoff. So if we're thinking that the surgery is going to last longer than 2 hours, or it requires surgical conditions where the patient has to be absolutely still, so they can't move, they can't twitch, that would necessitate a breathing tube, because the depth of anesthesia is going to be so deep that you're really not going to be able to breathe properly on your own, or the length of surgery is so long that you may get tired breathing on your own under anesthesia. And that's when we decide to go ahead and put that breathing tube in. It's basically another safety measure to make sure that we're getting your body enough oxygen and getting rid of the carbon dioxide waste during that period of time, and providing the optimal surgical conditions for your surgeon so that the surgeon can do a great job.
And I always like to think of it as that, we work as a team in the operating room and that your anesthesiologist is basically taking over for your brain at that moment. They're the person that is like making sure that you're breathing well. They're making sure you're warm enough. They're making sure your fluid's right. And that's all the stuff you normally do when you're conscious. But since
Exactly.
you're not there, they're the person doing it for you. So they're arguably one of the most important people in the room. A lot of people always ask, operating rooms are so cold. Why do we then put so many things on patients to keep them warm? Why is that so important?
So the act of putting somebody to sleep actually causes patients to become cold. So the temperature sensor and regulation in the brain goes to sleep, just like everything else in the brain goes to sleep. And so therefore, there's really your body can't regulate your temperature. Your body can't say, oh, I'm cold, I'm going to start shivering. That doesn't happen, which would be a normal process if you were awake. So we have to take over for that process and warm the patient externally. In addition, the operating rooms are so cold, and that's for infection control and comfort of the personnel in the room, since everybody's usually wearing a whole bunch of extra coats and things like that and gowns. So the operating room tends to be cold, and so that puts the patient at risk of becoming even colder outside of just getting the anesthesia that turns off the temperature sensor in the brain.
And, we always say that especially from the anesthesia standpoint and things, we don't want to see surprises. A boring case is a good case.
Absolutely. Absolutely.
So another thing that people who are very nervous about anesthesia will say is, oh my gosh, what happens if I wake up? I mean, what's your answer to something like that?
So that phenomenon is something that we call awareness under anesthesia. So it can happen in a few different scenarios. It is exceedingly rare, and that's what people, I think, don't understand. I think people see it in the news or see it on a TV show where the patient's, under anesthesia has a breathing tube, but, the show shows what's going on in their minds. The incidence of awareness under anesthesia is only actually 1 in every 10,000 anesthetics. And there are some really high risk people who have awareness under anesthesia. And those people include patients who are really, really sick, whose vital signs are very unstable before we even put them off to sleep. Those patients tend not to tolerate too much anesthesia because their vital signs are already pretty low. And so that puts you at increased risk. The other things that put you at increased risk are trauma surgeries, emergency surgeries. Basically, the patient has to be pretty sick in order for us to not be able to deliver the amount of anesthesia needed in order to keep them completely unconscious. And I think it's important to point out that there's different sort of levels of anesthesia. So in anesthesia, we consider it as a continuum of sleep. And so there are patients who undergo what we call twilight, and that's all IV. There's no breathing tube. And that in itself has a higher risk of patients sort of having some consciousness during the surgery, but they'll be pain-free. And we always have a conversation with our patients that you're going to have twilight. It's not a full general anesthesia with a breathing tube. So there's always a chance that you could have a sense of some things going around you, but you shouldn't be startled because that's actually part of the anesthetic, as opposed to the general anesthesia with the breathing tube where you're completely asleep and we've taken everything over.
Right. And so that's why you guys kind of make the decision sometimes if somebody, because we do have patients coming in, they're like very insistent upon doing one type of anesthesia, but it's really smart to listen to the people that are the experts because they can best guide you to know so that you don't get put into that type of position.
Absolutely. Absolutely.
Another question that gets asked a lot is the other one, which naturally you're scared about pain, right? Do you experience pain when you are under general anesthesia? And if you do, how do you handle that?
So patients do experience pain under anesthesia. But they're not conscious of it, right? So we've basically put them to sleep, turned off their brains for that little portion of the surgery. But we know that they experience pain because their vital signs will become altered. So when the surgeon makes incision, makes the first cut, we almost always see that heart rate rise, the blood pressure rise, which is an indication that the patient is feeling pain. And so based on what your vital signs are and your reaction to certain events during the surgery, we'll treat that with additional pain medicine. So a lot of our patients, when they wake up from anesthesia, they're actually relatively pain-free because we've been monitoring their vital signs and treating those things while they're asleep.
So there's really not a concern. If yes, you're experiencing pain, but if you're not mentally conscious and aware of it, then it's
Exactly.
not that you're actually asleep and hurting.
Exactly.
So, concerning kind of the aftermath, right? So somebody goes home and they've had general anesthesia. What's normal and what's not normal? And I know that's kind of a big question, but what can most people expect on an outpatient surgery basis after having general anesthesia?
Yeah, so basically we'll wash you in the recovery room usually about an hour after surgery to allow you to wake up from that anesthesia. But the anesthesia is not going to be out of your body in that hour of time that you're in the recovery room. So most patients will go home a little drowsy, tired feeling, and that's all normal. We always tell our patients that you're going to feel tired and sleepy for the rest of the day, and that the next morning it's going to be a brand new day. And so some patients, they'll go home. They might also feel nauseous, right? After there's some pretty high risk groups, women in general will have a higher risk of having some nausea and vomiting symptoms after anesthesia. So we do our best to try to treat that ahead of time before it occurs. But even with all of our best efforts and all of the anti-nausea medicine that we give them in the operating room while they're asleep, some patients still have nausea after anesthesia. Again, the surgeon will usually give a prescription for nausea for afterwards for the patient to take home. We encourage the patients to take that medicine, but it may just be that you'll have to just sort of sleep off the anesthesia tonight, and then again tomorrow will be a brand new day. Pain is another thing that can occur after anesthesia in your surgery. Your surgeon will also prescribe pain medication for you to take at home. We like to give patients some guidelines as to when to take that medication. I always tell my patients, try to keep yourself at a pain level of 4. Surgery is never going to be 0 pain because you just had surgery, but we don't want you to be a 10. 4 is actually a number that we know from studies. If you keep yourself at a 4 or below, basically take your pain medicine sort of proactively, you end up actually using less pain medication. That being said, in the last probably 5 or 10 years, we've really sort of gone to this push of having what we call enhanced recovery, where we don't use as much opioid or narcotic pain medication because of the risks of addiction afterwards. And so that entails the surgeon putting in blocks like you do for a lot of your surgeries, and that those blocks will last for up to a few days and provide some really significant pain relief. So some patients are totally okay just taking Tylenol at home because of the blocks that they've gotten.
I would say that's been I'm not actually sure how old that medication, the Exparel of the medication we're talking about is, how long it's been around, but it really has made a big difference with pain control because it lasts for at least 3 days.
Yes.
Which makes a big difference with staying on top of your pain, like you said, instead of chasing after it.
Exactly. Well, I think one of the questions I get asked a lot, or some concerns that I get, that the patients tell me a lot of, is that everybody always says, I want to wake up. Everybody has this sort of fear of not waking up from anesthesia. And we have to always remind them that that's a very, very rare complication, right? So the studies now with the improvements in monitoring and the drugs that we use, the risk of having a death under anesthesia is 1 in 200,000. So it is exceedingly rare. In the 1970s, that risk of dying under anesthesia was like maybe 1 in 10 to 20,000. So it was more prevalent. And but with advances in monitoring, so oxygen monitoring, heart monitoring, breathing monitoring, so we monitor the amount of carbon dioxide that your body is exhaling. With all those advances, we've been able to really cut the risk down to now it's about 1 in every 200,000 anesthetic.
And the way I always like to explain to patients is when you're young and you're healthy, which
Mhm.
majority of the plastic surgery patients fall into that category, and may also be older and healthy as well, that I mean, you have more chance of getting into a bad car accident
Yes.
than you necessarily having an issue under anesthesia. And I think that sometimes helps people kind of put that into perspective.
Exactly.
I also
Exactly.
think it's hard because it's the one place where no matter what you do, you've lost control over
Yes.
yourself
Yes.
because the medications always work.
Yes.
So this is just kind of fun. A lot of people will say, I swear I know I was awake when I went into the operating room, but I can't remember any of it.
Yeah.
Can you explain to people why that is?
So we use a medication called Versed. It is basically an anti-anxiety medicine. But in addition to the anti-anxiety properties that Versed contains, it also has what we call amnestic properties. So when we give you the Versed in the preoperative area just to calm your nerves down, and I like to tell patients that it's not going to put you to sleep, it just makes the world a little fuzzy. It just makes the lights go down a little bit, makes you feel like you've had a bottle of wine and you're just sort of relaxed and enjoying it. That medication actually erases your memory for a very short period of time. And so that's why patients, when they wake up from anesthesia, I'll ask them, well, what's the last thing you remember? And they're like, well, I remember you giving me some happy juice. And that was it. And that's all they remembered. And they're in the recovery room. And a lot of patients are like, we're done. When did you do the surgery? Are you sure you did the surgery? Yes, we did the surgery, Mrs. Smith. We're done. It's 4 hours later. You're just waking up from anesthesia. And the reason why is because of that medication that we give for anxiety.
Having observed that, it is pretty funny. People be like, no way, you just started, and it's like 6 hours later.
Exactly. Because you lose all sense of time, right? Because you're asleep, so you have no idea what time it is by the time you wake up.
Well, so some people have very varying responses of how they wake up in recovery. Some people wake up and they're just talkative and chatty and happy. And some people wake up and, they're just crying. Is there an explanation for why that is?
So basically, the anesthesia lowers our walls, is what I like to call it, right? And depending on what you went into surgery thinking about, depending on what's going on at home, the anesthesia has this effect of just sort of what we call disinhibition. So your walls, your normal emotional defenses all sort of start coming down. And so that sort of unleashes these emotions that people may have. I've had a patient before, and she'd experienced a death in the family a month prior, and she went into surgery very anxious, and we gave her the Versed just to calm her down. She had her surgery, and at the end, she just sort of woke up very, very tearful. And, it's like, are you okay? Can we do anything for you? And she had shared then with me that her loved one had died in the operating room. And so she was very fearful of that. And that's why when she woke up, her tears were not sad tears. They were happy tears because she had woken up from her surgery. So there's definitely that disinhibition, that the walls start coming down where people's emotions really start to show.
And I know we can't always control like how, what happens in our lives before we go into surgery, but I actually make a point of saying it pre-op, get some rest, do everything that doesn't stress you out, that's not on our no list, because I do feel like the more you come into surgery as peaceful and as stress-free as you can, that the better you kind of recover afterwards.
Absolutely. And I am of the same camp. The way you go in is the way that you come out. And it is definitely much easier for the patient and all the people taking care of you and your family if you can sort of center yourself and your mind in a place that's peaceful and stress-free going into surgery.
And I promise to any of our listeners who have inpatients that we never judge you for what happens in recovery.
No.
Because like Dr. Clowney said, it's not your fault. All those emotions are just let free. And so the nurses and the doctors there are all taking care of you and are happy to take care of you.
And we've seen it all. There's you haven't seen, so it won't be a surprise.
I do want to kind of also circle back to, we've talked a lot about anesthesiologists, but there are other people that help provide anesthesia care.
Well,
Can you tell us a little bit about like what CRNAs are and A's are and what their role is in the operating room?
yeah. So in some locations where we provide anesthesia under what we call a care team model. So you'll have an anesthesiologist who will be the supervisor of that care team, and they'll be supervising either a nurse anesthetist who basically is a RN who has specialty training in anesthesia, or they will be supervising a certified anesthesia assistant. And anesthesia assistants are relatively new to anesthesia, but they're the equivalent of a physician assistant or a PA. They're just the anesthesia version of a PA. And when we're in that care team model, the anesthesiologist is sort of the captain of that ship, and they are in charge of all the other mid-level providers. So the CRNA or the AA may actually be the person in the room controlling all of the amounts of medications and gases and the vital signs, but the anesthesiologist is immediately available and helps really with the anesthetic plan. And an anesthesiologist, the maximum amount of rooms they can cover is 4. Our group, we don't really like to do that. We usually do 2 or 3 rooms at the most. That allows us to really have an anesthesia provider with you at all times. So basically from start to finish, you'll have an anesthesia provider immediately available at your side.
And from a surgeon standpoint, it's, I don't have to worry about the overall health of the patient during that. Obviously, it's something I'm very focused on, but I can just focus on surgery and not have to worry, which is why I like the team model that your group does, because it really does put me at ease too, to know that I can just do my job while you guys are doing yours.
Well, that is really one of the most important things that we do, in addition to making sure that your patient is safe. And it is allowing you to just have the freedom to just focus on the surgery, as opposed to having to focus on the blood pressure and what's this and what's the urine output, those types of things. You can really focus on the surgery, and we'll take care of it.
Because there are some offices where that is what happens, is where the surgeon chooses to be in charge of that. Like I said, for me, I just want my attention focused on one thing. So I prefer this model. I think.
Yes.
As we're wrapping up, is there anything that you'd like to leave our listeners with about, just kind of if someone is about to undergo surgery, kind of things to keep in mind with their anesthesia?
Yeah, I think the most important thing is follow the instructions that you were given, right? Those instructions are really important for your day of surgery. One of the things that patients have a lot of questions about is our rules about not having anything to eat or drink after midnight, right? So that's what we call NPO. You can't have anything by mouth after midnight. Or you could have a little bit of cleared fluids in the morning as part of your enhanced recovery, but we have some very strict rules about that. And the reason why is because we want to decrease the risk of you potentially vomiting as you go off to sleep, and some of that vomit going into your lungs, which is what we call aspiration. So it is really for your safety to follow those rules that your surgeon and in the preoperative testing center give you, because it reduces your risk of having a bad event under anesthesia. You'll also receive instructions on which medications to take the morning of surgery, which medications you need to hold, and again, another way to lessen the risk of any complications in the surgery. So we're not trying to be mean, we're not trying to starve you or anything like that, but it's just really important because it mitigates a lot of the risk that we can experience.
So with the widespread use now of medications like Ozempic and Wegovy, that's also why now you might even have further restrictions to prevent this. Can you explain just a little bit with those specific medications what your protocol is?
Yeah, so Ozempic, they're basically that family of semaglutides, right? And what we know about those types of drugs is that they inhibit your stomach from emptying completely. So even though you've had nothing to eat or drink since midnight, your stomach could still be full of food contents that you had consumed earlier, because those medications tend to slow that gastric emptying. That slowing of that gastric emptying puts you at increased risk of, again, aspirating once we go under anesthesia. And so we will give you specific instructions about stopping that medication ahead of time. Those medications tend to last really long, so your stop time is usually about a couple of weeks before your planned surgery. If you've had some stomach issues, it may be we may ask you to hold it for even longer. And also, we'll ask some patients to do a clear liquid diet sometimes the day before, just to, again, mitigate that risk because of the side effects of those medications.
And super important. And I know a lot of people who feel like the medications have been so beneficial to them are like, I don't want to stop it all. But that's an important point. It's safety, and they do last in your system sometimes almost up to 5 weeks, maybe not at the same level. So you really are not going to suddenly go backwards with the gains that you've had or the losses that you've had with those medications by stopping.
Exactly.
Well, Dr. Clowney, thank you so much for joining us today. I hope this was very educational for everyone because, again, like I said, everybody researches the surgery, but they don't spend much time understanding how important the anesthesia aspect of it is. And hopefully it's made a lot of people a lot less anxious and nervous about having surgery.
Yeah, absolutely. A knowledgeable patient is the best type of patient.
Thank you so much for joining us on the Confidence Doc podcast. I can't wait to see you all again for our next exciting episode.
As we wrap up another episode of the Confidence Doc, I want to extend our heartfelt thank you for being a part of our community. If today's conversation resonated with you, remember that Dr. Rednam and her team are here to support you on your journey to self-confidence and beauty. Your story is unique, and it's our privilege to help you create the masterpiece that is your life. If you'd like to book a consultation with Dr. Rednam, you can visit her webpage at drrukminirednam.com. Fill out a contact form, and one of her coordinators will get with you accordingly.